Right now, in emergency rooms across the globe, the single most common reason people are walking through those sliding glass doors isn't a heart attack. It isn't, a catastrophic car crash, and it isn't a stroke. It's pain,
Yeah.
just raw, unyielding pain. And the terrifying reality of modern medicine is that the very systems built to cure that pain are, in a lot of cases, biologically rewiring patients to suffer from it forever.
It is the ultimate medical paradox.
Yeah.
You walk into a brightly lit trauma center looking for a lifeline, and the system basically throws you an anvil.
Right.
We've spent a century perfecting the science of saving lives,
Yeah.
but we are fundamentally failing at the science of preserving the quality of that life.
Welcome to this deep dive. I'm your host, and if you are listening right now, you might be a medical resident prepping for a clinical rotation or someone trying to navigate a fractured healthcare system for a loved one. Or maybe you're just intensely curious about the architecture of human suffering, how the body works and how it sometimes turns against itself. And I'm your resident clinical expert for today. I've spent 24 years in the ER, so I've seen this exact cycle play out thousands of times.
Exactly. Today, we are breaking down the definitive guide to what's often called the Brokeback Doc philosophy. And we have an absolute mountain of material on the table today.
Oh, yeah, it's dense.
Very dense.
Yeah.
It's this gritty, uncompromising collection of international clinical guidelines, emergency department triage protocols, highly technical psychological therapy manuals, and massive systematic reviews. And every single page is zeroed in on the most complex, misunderstood phenomenon in human biology:
Chronic pain.
chronic pain.
Right. And for decades, the medical establishment viewed pain merely as a symptom, like a side effect. Just a dashboard warning light telling you the engine was overheating.
A symptom of something else.
Exactly. But the data we are looking at today reveals a tectonic paradigm shift. Chronic pain is not a symptom. It is a standalone disease.
It is a structural, chemical, and anatomical alteration to the human nervous system.
Yeah.
And treating it requires an absolute teardown of how medicine currently operates.
So our mission today is to give you a shortcut to understanding this new reality. We are going to bypass the medical jargon and look at the brutal mechanics of how the healthcare system and your biology mishandle long-term suffering.
Yeah, we're following a very specific narrative arc here. First, we have to start at ground zero, right? The initial crisis, where acute pain meets the emergency room,
The front lines.
the front lines. From there, we'll examine the systemic failure that sets in when chronic pain takes hold. Like what happens when the fire's put out, but the fire alarm just won't stop ringing.
And finally, we'll map out the strategic pivot, because this isn't just theoretical. We're detailing the tactical, on-the-ground blueprint required to actually reclaim a functional life.
Right. It is a journey from the high-velocity chaos of the trauma bay to the microscopic neuroplasticity of your spinal cord, and ultimately to the collaborative reality of modern pain rehabilitation.
But to understand why the globe is currently drowning in a chronic pain epidemic, we have to start by looking at what the medical system is actually built to do. We have to look at the triage desk.
That is exactly where the friction begins.
Right.
Let's look at the sheer volume. Globally, pain is the undisputed heavyweight champion of chief complaints: osteoarthritis, back pain, severe headaches. These completely dominate the top 10 reasons people seek medical care.
Right.
But when you take a chronic, complex neurobiological issue and drop it into an emergency department, you are entering an environment built for something entirely different.
Because the ER is about survival, right?
Yes. I look at this through the lens of acute care protocols, and the reality is that the entire philosophy of emergency medicine boils down to triage and stabilization.
Yeah.
The ER is a beautifully brutal, hyper-efficient machine designed to prevent you from dying in the next 24 hours.
Right, the ABCs. Airway, breathing, circulation.
Exactly. It assesses immediate danger, neutralizes the threat, and discharges the patient to clear the bed for the next trauma. It's gritty, it's pragmatic, and it is entirely unsuited for nuanced long-term healing.
But it shines when the problem is acute. Like, if I come in with a shattered femur from a motorcycle accident, the ER is exactly where I need to be.
Oh, absolutely. The trauma bay is a marvel of modern science for nociceptive pain.
That's pain resulting from massive immediate tissue destruction, right?
Right. In that scenario, the protocols are rigid and they are highly effective. You have a patient in agonizing acute pain, their blood pressure is spiking, they're tachycardic. The immediate intervention is intravenous, titrated opioid therapy. Morphine or fentanyl pushed directly into the vein.
Just bypassing everything and going straight for the block.
Exactly. You establish IV access, you hook them up to a cardiac monitor, you have a pulse oximeter tracking their oxygen saturation,
Yeah.
and you have naloxone drawn up in a syringe right there in the room in case you suppress their respiratory drive too much.
Right, because opioids slow your breathing.
Right. It is a controlled, tactical strike against acute physiological shock.
But the protocols we're reviewing show a really interesting tactical shift even within that acute setting. Emergency physicians aren't just blindly pushing fentanyl anymore, are they?
No, not at all. They are hyper-focused on what happens the moment the patient walks out those sliding doors,
Yeah.
because the discharge is the most dangerous part of the ER visit.
Which is why we see this drug, tramadol, emerging so prominently in these emergency guidelines.
Yes, if you have a patient with severe acute pain who is eventually going to go home, you have to manage the pharmacology very, very carefully.
I was looking at the pharmacology of tramadol and the guidelines, and I want to make sure I understand the mechanism here. Because if opioids are the gold standard for blowing away pain, why are emergency docs relying on this specific, theoretically weaker drug? Is it just about avoiding the liability of prescribing stronger narcotics?
Well, no. I mean, liability is always a factor, but biologically it's about dual-action pharmacology and respiratory safety. Traditional opioids like morphine bind aggressively to the mu-opioid receptors in the brain and spinal cord.
Okay.
They block the pain, but they also bind to receptors in the brainstem that control your autonomous breathing. That is how opioid overdoses kill. You literally forget to breathe.
Wow. Okay, so tramadol avoids that.
Tramadol is different. It is a weak mu-opioid receptor agonist, so it gives you some of that direct pain-blocking effect. But its secret weapon is that it also acts as a serotonin norepinephrine reuptake inhibitor, or SNRI.
Wait, like an antidepressant?
Exactly like an antidepressant.
Yeah.
It floods the synapses with neurotransmitters that help the brain's descending pathways naturally inhibit pain signals.
So it's hitting the pain from two entirely different chemical directions.
Precisely. And because its affinity for the mu-opioid receptor is weaker, the risk of severe respiratory depression and hypotensive collapse is significantly lower. An ER doctor can administer tramadol, get the patient's pain down from a 9 to a manageable 4, and confidently discharge them knowing they aren't going to stop breathing in their sleep.
That makes total sense. And the guidelines point out a similar hyper-targeted approach for unrelenting migraines, too.
Oh, the migraine protocol is fascinating.
Right, like a patient arrives in the ER, they've been vomiting for 6 hours, the lights in the waiting room feel like laser beams, and the handful of ibuprofen they took at home did absolutely nothing.
Yeah, the migraine protocol is another perfect example of the ER's neutralize and discharge philosophy. The physician isn't trying to figure out the complex dietary or stress triggers that cause the migraine. They don't have time for that.
Right.
They're trying to abort the acute vascular crisis in the brain right then and there. They'll start with an aggressive antiemetic to stop the vomiting and allow oral absorption, combined with high-dose aspirin or paracetamol.
And if the pain doesn't break from that,
Then they escalate to triptans.
and triptans work by forcibly constricting the blood vessels, right?
Yeah, they are selective serotonin receptor agonists. During a migraine, cranial blood vessels painfully dilate and become inflamed. They throb. Triptans bind to specific serotonin receptors on those blood vessels, forcing them to constrict back to their normal size while simultaneously blocking the release of pro-inflammatory neuropeptides.
So the attack breaks.
The attack breaks, the crisis is solved, the patient goes home.
But, and this is the crux of the whole issue, this is exactly where the brilliance of the emergency department becomes its fatal flaw. The very mechanism that makes the ER so incredibly effective at handling an acute crisis is the exact mechanism of failure for treating chronic pain.
Right. It's what the literature refers to as the triage trap.
Let's break that down because it feels like the core of the systemic failure. If I take a long-term, structurally complex problem and hand it to a system built for 24-hour survival, what actually happens in that exam room?
You get a collision of opposing realities. I mean, the emergency department is philosophically structured to treat acute nociceptive damage, the broken bone, the burn, the laceration. It operates on the premise that the pain is a direct one-to-one reflection of tissue damage.
Tissue damage equals pain.
Right, but chronic pain, pain that has persisted for months or years after the initial injury has healed, it operates on entirely different biological hardware. It is no longer just about tissue.
It's like rebooting a computer to fix a hardware virus. The ER reboots the system with a potent painkiller. You get a brief, maybe 10-minute black screen where everything seems fine and the pain drops. But the virus is physically embedded in the hard drive. Once the system powers back up, the pain is right back where it was.
That is exactly the dynamic. When a chronic pain patient enters this acute focus system, they receive what researchers call snapshot care.
Snapshot care.
Yeah. The clinician evaluates the patient within a microscopic 20-minute window. They see a human being in severe distress. Their training dictates that distress requires immediate chemical intervention. So they administer a rapid-acting analgesic, perhaps write a very short-term prescription, print out discharge paperwork, and send the patient back out into the night.
It solves the next 2 hours.
But it does absolutely nothing to address the underlying disease driving the next 2 years.
And arguably, it makes the next 2 years much worse because now you are introducing powerful, potentially addictive substances without any long-term management strategy.
Right, worse than that, you are creating massive psychological friction. When an entire medical culture is addicted to the dopamine hit of fixing things, quickly diagnose, treat, cure, discharge, it generates a profound mismatch in expectations. The patient, desperate for relief, expects a cure. The doctor, trained as a healer, expects to provide one.
And when the patient's chronic pain fundamentally rejects that acute intervention,
The system breaks down into mutual resentment. The patient's pain returns the next day. They feel abandoned, gaslit, and invalidated by a system that essentially pushed them out the door. And the clinician, who relies on objective markers of success, feels frustrated and helpless.
because they couldn't fix it.
Exactly. And over time, that helplessness calcifies into cynicism. This is where you get the gritty ER vet mentality. The doctor starts viewing the returning patient as difficult or, worse, drug-seeking, while the patient views the medical establishment as incompetent and callous.
Wow. Which brings us to the biological reality of what is actually happening inside the patient. If the triage model fails because chronic pain isn't just a long-lasting acute injury, then what is it? The medical guidelines divide pain into 3 very distinct biological buckets: nociceptive, neuropathic, and nociplastic.
Right, we touched on nociceptive. That is the classic, straightforward tissue injury. Neuropathic pain is when there is actual, verifiable structural damage to a nerve
So
itself.
like a physical wire being cut.
Exactly. Think of a herniated disc mechanically crushing the sciatic nerve, or the peripheral nerves dying off in diabetic neuropathy. The physical wire carrying the signal is frayed and sparking.
But the third category, nociplastic pain, this is the paradigm shift. This is the biological hardware virus.
Nociplastic pain fundamentally changes how we have to view human biology. It is pain that arises from altered nociception, despite no clear evidence of actual tissue damage or discrete nerve damage.
So the system itself has been reprogrammed.
Yes.
The concept I kept seeing over and over in the psychological manuals and the neurobiology papers was this idea of the broken fire alarm.
It is the single most accurate way to conceptualize central sensitization. Your central nervous system, your brain and spinal cord, acts as a highly sophisticated fire alarm. Its evolutionary purpose is to detect changes in your environment, assess them for threat, and ring a bell to compel you to protect yourself.
Right. And that ringing bell is the sensation of pain. So if I touch a hot pan, the peripheral nerves send a signal up my arm to my spinal cord. The spinal cord relays it to the brain. The brain evaluates the threat and rings the alarm. I feel pain, and I pull my hand away. The system works perfectly.
Exactly. But in a nociplastic state, in chronic pain, that alarm system structurally breaks. The internal wiring of the smoke detector becomes hypersensitized.
How so?
Well, it initially goes off because there was a raging fire. Maybe you had a severe back injury or major surgery. The alarm blared for weeks while you healed. But over time, the calibration of the sensors gets corrupted. Long after the tissues have completely healed and the fire is out, the alarm gets so sensitive that it starts blaring at 120 decibels just because you plugged in the toaster.
Or because the ring got a little huge.
Right, the fire is completely gone, but the alarm is still screaming. And the critical point here is that the noise of the alarm, the agonizing pain the patient feels, is 100% real.
That cannot be overstated. The pain is not imagined. The pain is biologically identical to the pain of an acute injury. But the acute threat to the tissue no longer exists.
Right.
Let's dig into the actual mechanics of that, because just dropping the phrase central sensitization isn't enough. How does a biological alarm get physically stuck in the on position?
We have to look at neuroplasticity. Usually when we talk about neuroplasticity, we frame it as a superpower. It's the brain's ability to reorganize itself by forming new neural connections throughout life.
It's how we learn things.
Yeah, it's how a child learns to play the violin. Neurons that fire together wire together. Your brain creates incredibly efficient superconducting pathways for tasks you repeat.
But neuroplasticity is completely agnostic. I mean, it doesn't care if the pathway it's building is a piano concerto or sheer agony.
Exactly. It is a dark side to neuroplasticity. When you have an initial injury that sends constant high-volume pain signals into the dorsal horn of your spinal cord day after day, the nervous system basically says, wow, we're using this pathway a lot. We need to make it more efficient.
And how does it structurally do that? Because the research mentions wind-up pain at something called the NMDA receptor.
Right. Let's look at the cellular level. In a healthy spinal cord, you have these NMDA receptors sitting on the neurons that relay pain to the brain. Normally, these receptors are dormant. They are literally plugged up by a magnesium ion.
Like a physical plug.
Yes, it's a biological safety cap.
Mm-hmm.
Normal, everyday sensory input, like the feeling of your shirt on your back, isn't strong enough to knock that magnesium plug out.
So the signal gets filtered out, you don't feel the shirt.
Right. But when you suffer a severe injury, the constant violent barrage of pain signals from the peripheral nerves forcefully kicks that magnesium plug out of the NMDA receptor.
Hey, literally kicks it out.
Literally knocks it out of place. And suddenly the receptor opens wide. Calcium floods into the neuron. And calcium acts as a massive biological messenger. It fundamentally alters the architecture of the cell.
It changes how the cell behaves permanently.
Well, it lowers the threshold for firing. The neuron becomes highly excitable. Now, even a tiny, non-painful stimulus like light pressure or normal movement triggers a massive cascade of pain signals to the brain. This is called allodynia.
Wow.
And on top of that, the calcium flood triggers the activation of glial cells, specifically microglia, in the central nervous system.
Glial cells, those are the immune cells of the brain and spinal cord, right?
They are. And when they get activated by this constant pain signaling, they assume the body's under attack. They start dumping a toxic soup of inflammatory cytokines into the spinal fluid, specifically interleukin-1 beta.
That sounds bad.
It's terrible. This humoral cascade tells the neurons to start expressing COX-2 enzymes, which produces prostaglandins, further inflaming the nervous system. You are literally altering the gene transcription of your dorsal horn neurons. They are manufacturing the tools to keep themselves inflamed. The biological hardware is fundamentally compromised.
Which perfectly aligns with the neuromatrix model of pain. This isn't just a simple electrical wire running from the toe to the brain. The brain is actively constructing the pain experience.
Ronald Melzack proposed the neuromatrix theory to explain exactly this. Pain is not a passive reception of tissue damage. Pain is a multidimensional experience entirely constructed by the brain's neural networks.
It's taking in all this data.
Yeah, the brain takes in sensory input, compares it against past memories, evaluates current stress levels, factors in anxiety, and then outputs a sensation of pain if it decides the organism needs protecting.
But here is where we hit a massive, brutal communication hurdle. I'm imagining a clinician sitting in an exam room with a patient who has been crippled by back pain for 3 years. The doctor has ruled out tumors, fractures, and disc herniations. If that doctor looks the patient in the eye and says, your tissues are healed, the pain is being generated by your brain due to neuroplasticity and altered NMDA receptors.
So the patient will immediately viscerally react with, are you telling me I'm crazy? Are you saying I am making this up for attention?
Right. It's the most disastrous breakdown in modern medicine. Because culturally, we have this ironclad, completely false dichotomy. We believe that if something is physical, it is real and legitimate. If something is mental or generated by the brain, it is imaginary, weak, or fraudulent.
And that false dichotomy destroys lives. How clinicians bridge that gap is the make-or-break moment in treating chronic pain. You cannot just throw neuroscience at a patient and expect them to feel validated.
So how do you explain a broken fire alarm without making the patient feel like you're calling them a hypochondriac?
By validating the biology before you ever mention the brain. You have to ground it in undeniable physical reality. A skilled clinician will say, look, your pain is 100% real. If I put you in a functional MRI scanner right now, I can point to the pain centers of your brain and watch them light up like a thunderstorm. The sheer volume of pain you are experiencing is biologically measurable.
Validating the experience.
But the source of the pain is no longer a torn muscle in your lower back. The source is a nervous system that has physically rewired itself to protect you too aggressively. Your brain is manufacturing real, agonizing pain to protect a back that actually no longer needs protecting.
It's reframing the pain from a sign of damage to a sign of an overprotective system.
Exactly. It's not in your imagination. It is etched into your neurocircuitry. And the crucial pivot is this. Because it is a learned neurocircuitry, it can be unlearned.
Oh,
Yeah,
wow.
neuroplasticity works in both directions, but unlearning it requires an entirely different set of tools. You cannot surgically excise a sensitized neural pathway. You cannot numb an activated microglial cell with an opioid pill.
Which brings us to the next massive realization, and frankly, the darkest part of these medical guidelines. A broken fire alarm screaming in your nervous system 24 hours a day doesn't just exhaust your physical body, it mounts a relentless cellular level attack on your psyche.
Absolutely.
We have to dive into the bidirectional link between chronic pain and severe mental illness.
You cannot disentangle the two. I mean, to treat chronic pain while ignoring the patient's psychological state is biological malpractice. The umbrella reviews we are analyzing cover nearly 1 million participants, and the comorbidity rates they reveal are astronomical.
I was tracing my finger down these tables, and the numbers are just staggering.
Mhm.
In patients diagnosed with post-traumatic stress disorder, up to 96% of them experience comorbid chronic pain. 96%.
Yeah.
It is effectively a universal symptom of the trauma.
It is the physical manifestation of hypervigilance.
And the overlaps continue. Major depressive disorder sees a 53% to 65% overlap with chronic pain. Bipolar disorder sits at 23.7%. Schizophrenia is nearly 30%. Even neurodevelopmental conditions like ADHD and autism show massive, statistically significant overlaps with chronic pain syndromes.
But the critical insight here isn't just that these conditions exist at the same time. The insight is the mechanism of action. The relationship is entirely bidirectional. It is a self-sustaining biological loop.
The guidelines heavily reference Mendelian randomization studies to prove this. And we should probably clarify what that means, because it's a brilliant way of proving causality, not just correlation.
Right, it's a fascinating epidemiological tool.
Hmm.
In standard observational studies, if you see that people with depression also have high rates of back pain, you don't know which caused which. Or if a third factor, like poverty, caused both.
You can't prove the direction.
Exactly. Mendelian randomization gets around this by using genetics as a natural experiment. We know certain genetic variants predispose people to higher risks of depression. By tracking large populations with these specific genes, researchers can isolate the variables.
So they use the genetic predisposition as a perfectly clean control group.
Exactly. And what the Mendelian randomization proves is terrifying. Having multi-site chronic pain structurally causes a massive increase in your risk of developing major depressive disorder. The odds ratio goes up by a factor of 1.88.
So the sheer wear and tear of pain fundamentally degrades the brain's ability to maintain a healthy mood.
But it works in reverse, too.
Wait, really?
Yes. Having a genetic predisposition to major depressive disorder raises your risk of developing chronic regional pain by a factor of 1.26. The depression literally causes your biology to generate pain.
I need you to explain the exact biological pathway of that. Like, how does an emotional state, a mood disorder, reach down into the physical body and create a sensation of pain?
It comes down to the HPA axis, the hypothalamic pituitary adrenal axis. This is the core engine of your body's stress response. When you encounter a threat, your hypothalamus signals your pituitary gland, which signals your adrenal glands to flood your system with cortisol and adrenaline.
Fight or flight.
Right. Your heart rate spikes, your muscles tense, and your immune system temporarily suppresses inflammation to prepare for acute trauma. But in major depressive disorder or chronic trauma, that system gets locked in the on position.
The fire alarm again?
Yep. The HPA axis becomes utterly dysregulated. You are basically marinating in a constant toxic soup of cortisol.
And what does constant cortisol do to the brain?
It is deeply neurotoxic.
Yeah.
High chronic levels of cortisol literally atrophy the hippocampus, the part of the brain responsible for memory and emotional regulation.
It shrinks it.
It physically shrinks it. Simultaneously, it enlarges the amygdala, the brain's fear center. This state of constant chemical stress, known as allostatic load, dramatically alters how the brain's salience networks process incoming sensory information.
The salience network being the part of the brain that decides what stimuli to pay attention to.
Yes. The anterior cingulate cortex and the insula. These emotional networks are anatomically intertwined with the physical pain networks. When the brain is physically degraded by the cortisol of depression, it loses the ability to inhibit sensory noise.
So what happens?
It takes a normal, benign physical sensation like the digestion of food in your gut or the normal mechanical tension in your neck muscles and misinterprets it as a severe threat.
So if you are deeply depressed, your brain is chemically primed to invent pain out of thin air. And if you are in pain, the constant firing of the HPA axis bathes your brain in cortisol, physically destroying your emotional resilience. It is a perfect inescapable loop.
Which brings a crushing human toll.
Yeah.
We have to address the most sobering statistic in the entire stack of research.
Yeah.
The lifetime prevalence of suicide attempts in people suffering from chronic pain ranges from 5% to 14%.
God, that number is chilling. It tells you exactly how inescapable this loop feels from the inside. When the pain degrades your mind and your degraded mind amplifies the pain, the patient feels entirely trapped in a burning building.
And this leads to a highly specific, often lethal phenomenon within the medical system known as diagnostic overshadowing.
This is when the medical system's own biases actually blind them to the biology, right?
Right. Diagnostic overshadowing occurs when a patient with a documented psychiatric illness presents to a clinic complaining of severe physical pain, and the clinician unconsciously attributes the physical symptom entirely to the mental illness.
Ah, the doctor looks at the chart, sees general anxiety disorder or bipolar disorder, and immediately assumes the pain is psychosomatic, like, oh, your chest hurts, it's just a panic attack. Oh, your stomach is in agony, it's just your depression manifesting.
It is the ultimate dismissal, and the consequences are catastrophic. The literature specifically highlights patients with schizophrenia. Because of the neurobiological changes we just discussed, individuals with schizophrenia often exhibit altered, sometimes significantly elevated pain thresholds.
Meaning they don't feel it as early.
They might not process nociceptive signals normally, so by the time they actually complain of physical pain, the tissue damage is usually severe.
But because of diagnostic overshadowing, the ER doctor or the primary care physician dismisses them.
Exactly. The doctor assumes the complaint is part of a delusion or somatic symptom disorder. The pain is ignored. And because the pain is ignored, the underlying pathology goes uninvestigated.
That's horrifying.
It is. This phenomenon is a primary reason why patients with severe mental illness routinely experience delayed diagnoses for life-threatening, purely physical conditions, like late-stage metastatic cancer. The medical system's inability to hold two opposing truths simultaneously, that a patient can be deeply mentally ill and experiencing catastrophic physical pathology, literally kills people.
That is profound. And for the patient navigating this, the psychological stages of processing this nightmare are incredibly complex. The psychological manuals detail the stages a patient goes through, and denial is a massive roadblock.
Denial is a survival mechanism. When your body is failing you, the immediate psychological defense is to reject the reality. The mindset is, this isn't happening to me. I was running marathons last year. I just need to find the right surgeon or the right experimental injection, and they will fix the broken part, and I will get my life back.
If the pain and the depression are feeding each other in this neurobiological loop, and the patient is stuck in denial, continuously hunting for a magical surgical cure, how does a clinician even begin to break them out of that cycle?
It requires an immense amount of delicate, compassionate confrontation. Breaking out of denial means grieving. The patient has to mourn the loss of their old life, the pain-free, carefree existence that they might never fully get back.
That's a hard conversation.
The hardest. As long as a patient is desperately hunting for a purely biomedical cure, a scalpel or a needle, they remain in a passive state. They are a victim waiting for a rescuer. And the medical system, bound by the limitations of the triage trap, cannot rescue them. They have to become active participants in their own rehabilitation.
The economic and social devastation during that period of denial is staggering, too. The data calculates that comorbid depression and anxiety add an extra $5,208 per patient annually in healthcare costs.
And that's largely driven by constant fruitless emergency room visits, redundant imaging, and catastrophic losses in workplace productivity.
But the social cost is even darker. The sociological data points out this deeply tragic observation. As a patient embarks on what the literature calls a career of chronicity, the very architecture of their social network collapses.
It's a slow, isolating erosion. Initially, when a person gets hurt, their informal support system rallies. Spouses take over chores, friends bring casseroles, coworkers check in.
Everyone wants to help the acute injury.
Right. But as the acute injury drags into chronic pain and the depression sets in, empathy fatigue occurs. Friends stop calling. The patient, exhausted by having to constantly explain why they can't go to dinner or attend a wedding, isolates themselves.
They shrink their world down to the size of their bed.
And as that informal network evaporates, they're forced to shift their reliance entirely to formal systems. Doctors, physical therapists, pain clinics, pharmacists. The clinician effectively becomes the patient's only remaining social outlet. You aren't just going to the clinic for medicine, they're going for human contact.
Which brings us to the crux of the systemic failure. We have a highly complex neurobiological disease heavily intertwined with severe psychiatric distress and social isolation, and we are asking a purely biomedical system to measure it.
Yeah.
The friction here centers entirely around the search for the baseline truth.
This is where the objective reality of modern science smashes into the subjective reality of human consciousness.
Yeah.
The fundamental, unavoidable problem with pain is that it exists entirely within the mind of the sufferer. There is no blood test for central sensitization.
Right.
There is no structural MRI that can capture a broken fire alarm.
The clinical definition provided by Margot McCaffrey in 1968 is heavily cited in the sources. She defines pain simply as whatever the experiencing person says it is, existing whenever he says it does.
Philosophically, it is a beautifully validating, patient-centered definition. It honors the lived experience. But logistically, inside a hyper-optimized, legally fraught, data-driven medical system, it's an absolute nightmare to operationalize.
Right. We live in an era of microscopic medical precision. We can sequence the human genome in hours. We can inject radioactive isotopes and watch a tumor metabolize sugar in real time on a PET scan. Yet, for the single most common reason a human being seeks medical care, the pinnacle of our diagnostic technology is asking a patient to point to a laminated chart of smiley and frowny faces and pick a number between 1 and 10.
The 1 to 10 scale, the visual analog scale, it is a profoundly flawed instrument. I mean, a 7-bit and a 20-year-old athlete who just sprained their ankle is entirely different from a 7-bit to a 6-year-old who has lived with agonizing fibromyalgia for 2 decades.
And this reliance on self-reporting creates a massive trust deficit. The medical system is built on the bedrock of objective verification. A doctor wants to see an elevated white blood cell count to diagnose an infection. They want to see a jagged white line on an X-ray to diagnose a fracture.
Right.
But nosoplastic pain actively defies objective measurement.
That is exactly where the patient feels deeply gaslit. The patient sits in the office, their nervous system screaming in agony, and the doctor puts an MRI on the light box and says, look, your discs are perfectly fine. Your spinal canal is wide open. There is nothing structurally wrong with you. Like, I have the truth right here. Yes. When the objective tests are pristine, the subjective complaint is often viewed with deep suspicion. The unspoken implication is, I think you are faking this.
Because if the baseline truth is entirely unmeasurable, the clinician is forced to rely solely on their own interpretation of the patient's suffering.
And this subjectivity is exactly what causes the system to fail marginalized patients so consistently. When a doctor has no objective biomarker to anchor their diagnosis, they have to evaluate the patient's credibility. How articulately is the patient explaining their pain? Does their body language match their reported pain score?
Which introduces massive bias.
Massive bias. The moment human interpretation becomes the primary diagnostic tool, you open the floodgates to disparate treatment.
The data on who gets inadequate treatment is glaring. The guidelines highlight that older persons, individuals with cognitive impairments, and those who simply don't communicate their distress in a way the clinician inherently expects or validates, routinely receive substandard pain management.
If a patient with dementia is thrashing in bed, is it delirium? Or are they experiencing agonizing neuropathic pain? They simply lack the cognitive ability to articulate. If the clinician can't confirm it, they often undertreat it. The therapeutic alliance, the absolute trust between patient and provider, is the only bridge across that diagnostic void.
If I'm an ER doctor or a primary care physician and I have, 15 minutes to evaluate a patient with complex, unmeasurable chronic pain, how do I actually build that therapeutic alliance? How do I navigate this without leaning on a useless MRI?
By consciously overriding your medical conditioning, you have to surrender the desire for objective proof and embrace the patient's narrative as the clinical baseline. You have to accept that the patient's context, their stress, their environment, their history aren't distractions from the diagnosis. They are the diagnosis.
But achieving that level of deep empathetic investigation in a system that budgets 15 minutes per patient is a monumental task.
Which is exactly why the guidelines state that the current biomedical model must be dismantled.
Right. We've mapped the failure of the triage trap. We've looked at the neurobiological horror of the broken fire alarm and the psychiatric devastation it brings. We see the total collapse of objective measurement. It is time for the strategic pivot.
The transition from the biomedical model to the biopsychosocial model. This is the cornerstone of modern evidence-based pain rehabilitation.
Let's define the biopsychosocial model precisely. What does that actually mean in a clinical setting?
It is the radical acceptance that human suffering cannot be siloed. It acknowledges that the experience of pain is dynamically generated by the continuous interaction of three pillars: biological factors like tissue damage, genetic predispositions, and central sensitization; psychological factors like clinical depression, anxiety, fear avoidance, and catastrophizing; and social factors like socioeconomic status, toxic work environments, isolation, and access to care.
So they all feed into each other.
You cannot isolate and treat one pillar. If you surgically fix a herniated disc but ignore the patient's crippling PTSD and poverty, the pain will persist.
To actualize this massive philosophical shift, the guidelines lay out a very specific logistical framework. They call it the stepped care model. I want to walk through exactly how this works because this is the actual blueprint for recovery.
The step care model is essentially a triage system, but reverse engineered for long-term chronicity rather than acute trauma. The goal is to match the intensity of the intervention to the complexity of the disease. You don't use a sledgehammer to crack a nut, but you also don't put a Band-Aid on a hemorrhage.
Step one is primary interventions. What does this look like?
Step one is early intervention in a primary care setting, usually for pain that has lasted just a few weeks. The interventions are brief, educational, and highly targeted at preventing the chronicity before it sets in. The absolute primary target here is dismantling fear avoidance.
Fear avoidance, the kinesiophobia.
Yes, the fear of movement. It is human nature to stop moving when something hurts. But with musculoskeletal pain, immobility is poison. If a patient tweaks their back and immediately takes to their bed in terror of making it worse, their stabilizing muscles rapidly atrophy. Their joints stiffen.
And the anxiety goes up.
The lack of movement spikes their anxiety, which heightens the nervous system's sensitivity. Step one is intense education by a clinician or physical therapist teaching the patient a vital mantra: hurt does not equal harm.
Meaning the pain they feel when bending over isn't actively ripping their spine apart. It's just a hypersensitive alarm.
Exactly. Teaching them that it is safe to move, even if it is uncomfortable. You prescribe gentle activity to keep the neuroplasticity from hardwiring a pain response.
But what if the patient fails step one? The pain persists for 6 to 8 weeks and they can no longer work.
Then you escalate to step two, secondary interventions. This requires increased clinical intensity. You bring in targeted physical therapy protocols. You might introduce short-term psychological interventions like a few sessions of cognitive behavioral therapy to manage the mounting stress.
Okay.
And you introduce active pharmacological management, perhaps SNRIs or gabapentinoids targeting the nerve pain rather than opioids.
And if the disease is completely intractable, like the patient has been suffering for years, they have comorbid depression, they are entirely isolated, and their biological alarm is blaring constantly.
That requires step three, tertiary interventions. This is the heavy artillery. It involves complex interdisciplinary care. The patient is referred to a specialized pain rehabilitation clinic where a team of experts operates in complete synchronization.
The sources outline a philosophy for this level of care called the 5C approach. It's a completely different language than the trauma bay.
It is the antithesis of the ER. The 5Cs stand for continuing care, accepting that there is no quick cure, and the goal is lifelong management. Comprehensive care, addressing the whole person. Coordinated care, ensuring the physical therapist is talking directly to the psychiatrist. Community orientation, integrating the patient back into society.
And the last one.
Crucially, person-centered care. The ER focuses on what is the matter with the patient. The 5C approach focuses on what matters to the patient. Is their goal to run a marathon or just to be able to sit on the floor and play with their grandchildren?
The most profound shift here is the transition from passive to active interventions.
This is the hardest pill for a patient to swallow. Passive interventions are things done to you. A surgeon cuts you open. A doctor injects a steroid into your joint. A pharmacist hands you a pill to swallow. While passive interventions have a role in acute care, they have severely limited efficacy for complex nosoplastic pain.
Why?
Because passive interventions do not rewire the brain.
To fix neuroplasticity, you have to use neuroplasticity.
Exactly. The patient has to engage in active interventions. Physical movement, cognitive restructuring, sleep hygiene, meditation. They have to do the grueling daily work of exposing their nervous system to normalcy, so the brain slowly learns to turn the fire alarm off.
I was looking at the massive tables and the clinical guidelines detailing the sheer variety of therapies. You have hands-on manual massage, you have hands-off progressive exercise loading, you have electrotherapies like 10NS units firing electrical impulses into the skin.
Mm.
You have intense dietary interventions to lower systemic inflammation. It is a complete shotgun approach. You're hitting the pain from every conceivable angle.
Because the disease is attacking from every conceivable angle. The physiotherapy manual we reviewed has a brilliant visual for this. It maps out the downward spiral and the upward spiral.
Walk us through the mechanics of those spirals because it perfectly visualizes the biopsychosocial trap.
The downward spiral starts with a purely physical insult, an injury that causes pain. Because of the pain, you develop fear avoidance and stop moving. Because you stop moving, your muscles decondition and weaken, placing more mechanical stress on your joints.
Which hurts more.
Right. Because you're stuck at home, you become socially isolated. Isolation breeds severe life stress and depression. The depression floods your brain with cortisol, which utterly destroys your sleep architecture.
And without sleep, the brain can't clear out neurotoxins.
Right. The lack of restorative sleep suppresses your immune system and dramatically lowers your mechanical pain threshold. Your central nervous system becomes hypervigilant. Now, the baseline pain is twice as loud as it was at the start of the spiral, which creates even more fear avoidance. The gravity of the spiral accelerates.
So how does a patient engineer an upward spiral?
You don't try to stop the pain directly. You attack the periphery of the spiral. You start with rigorous sleep hygiene to regulate the brain's baseline. Better sleep gives you the micro boost of energy needed to practice cognitive behavioral techniques to manage your depression.
Okay, so fixing the sleep helps the mood.
Managing the emotional stress lowers the cortisol levels, which takes the edge off the central sensitization.
That slight drop in sensitivity allows you to start moving again.
Exactly. You start gentle, graded physical activity. Normal activity begins to rebuild the atrophied muscles. Stronger muscles provide better mechanical support, which reduces the nociceptive signaling. Feeling physically capable gives you the confidence to leave the house and see friends.
Building the social network back.
Social connection releases oxytocin and endorphins, which are potent, natural analgesics. Step by step, you reverse the momentum. The volume of the entire central nervous system dials down.
But climbing out of a gravity well requires a massive amount of thrust. I mean, a patient drowning in the downward spiral cannot just bootstrap their way out of it through sheer willpower. The literature is unequivocal. To execute this strategic pivot, you have to build a team. You have to build a personal cabinet of experts.
Optimal management demands a multidisciplinary team. The guidelines explicitly mandate a coordinated roster. Clinical psychologists, specialized nursing staff, physical therapists, occupational therapists, clinical pharmacists, and primary care physicians. It is the gold standard of care.
But let's ground this in reality for the listener. If I am sitting on my couch right now, immobilized by chronic back pain, and I hear multidisciplinary team, I'm thinking, great, I need a referral to the Mayo Clinic and I need $50,000.
Yeah, right.
What if I live in a rural area? What if I am navigating a heavily fragmented, deeply flawed public health system? How do I actually start assembling this cabinet on a Tuesday morning?
That is the gritty operational reality. Most people do not have access to a world-class, all-in-one interdisciplinary pain center, so the patient has to become their own chief of staff. You have to actively build the network yourself using the resources available. Your primary care physician is your base of operations, but you have to actively recruit the other members and force them to communicate.
Let's break down the specific tactical roles of this cabinet, starting with the psychological interventions. The manuals heavily focus on CBT, CP, cognitive behavioral therapy for chronic pain, and ACT, acceptance and commitment therapy.
The clinical psychologist is arguably the most vital member of the cabinet, and we must be incredibly clear. The psychologist is not there to tell you the pain is all in your head. They are there to help you dismantle the cognitive evaluative component of the pain experience.
Explain the cognitive evaluative component.
When you feel a spike of severe pain, your brain immediately evaluates what that pain means. The CBT manual teaches patients to track their SUDS, their subjective units of distress scale. It also trains them to identify and assassinate ANTs.
ANTs, automatic negative thoughts.
Exactly. An automatic negative thought is catastrophic framing. You bend over, your back spasms in agony, and the ANT instantly fires off in your brain. My spine is degrading. I'm going to end up in a wheelchair. My spouse is going to leave me because I'm a burden. My life is entirely over.
And from a biological standpoint, that specific thought triggers an instantaneous fight-or-flight panic response, flooding the system with adrenaline and cortisol, which physically makes the back spasm violently worse.
The thought acts as a biological amplifier. The psychologist trained you in cognitive restructuring. You learn to catch that thought mid-flight examine it logically, and replace it. My back is spasming because my nervous system is overly sensitive. I'm safe. I've survived this before. I'm going to do my breathing exercises until the alarm turns off.
You are using conscious thought to manually override the brain's hardware virus.
The sources also place a massive emphasis on nursing staff. Nurses seem to play a very specific structural role in this cabinet.
Nurses are the critical bridge. The reality of modern medicine is that doctors are aggressively rushed. The power dynamic in an exam room can be incredibly intimidating for a vulnerable patient. They might forget all their questions or be afraid to admit they aren't doing their exercises. Patients are almost universally more at ease with nursing staff.
The nurse acts as the translator. They translate complex, high-level biomedical jargon into actionable daily routines. They are the ones doing the follow-up calls, checking on medication side effects, and providing the deeply necessary emotional validation that keeps the patient engaged in the fight.
And the physical therapist, what is their specific mandate?
They are the biomechanical engineers. They do not just give you a sheet of stretches. They practice graded exposure. They help you identify exactly which movements trigger your neuroplastic alarm, and they safely, incrementally expose you to those movements. They teach your central nervous system, rep by rep, that movement is not inherently dangerous.
The CBT manual we reviewed provides some incredible tactical advice for self-management, too. It fundamentally shifts the patient from a passive hope that a doctor will fix them to treating their pain management as a highly structured, almost militaristic daily routine.
Failing to plan is planning to fail. That is the core ethos. The manual mandates the use of a rigid weekly activity schedule. You do not wake up and wait to see how your body feels before deciding what to do. You plan your activities based on pacing.
Because if you wait for a good day, you inevitably overdo it.
It's the classic boom and bust cycle. A patient has a low-pain day, so they decide to clean the entire house, mow the lawn, and go grocery shopping. By 4 p.m., their nervous system crashes into a catastrophic flare-up, and they spend the next 3 days bedridden.
The crash.
The crash. The weekly activity schedule forces you to pace. You schedule 30 minutes of cleaning, followed by a mandatory 15-minute scheduled relaxation technique, followed by a short walk. You intentionally meter your energy to avoid triggering the central sensitization.
And the manual specifically mentions creating a concrete, written flare-up plan. This seems absolutely essential.
It is the parachute. A flare-up is biologically inevitable. The neuroplasticity will occasionally act up, triggered by a bad night of sleep or a stressful event. If you do not have a plan, a sudden spike in pain sends you straight into a psychological panic. The catastrophic thoughts take over, the cortisol floods the system, and you end up rushing straight to the emergency room, right back into the triage trap.
Where they give you a snapshot dose of an opioid and send you home.
Exactly. A written flare-up plan interrupts that cycle. It is a pre-written, highly logical list pinned to your refrigerator, it says. When the pain spikes to an 8, I will not panic. Step 1. I will do my progressive muscle relaxation routine for 20 minutes. Step 2. I will apply a heating pad and take my specific prescribed rescue medication. Step 3. If the pain does not break, I will call the 24-hour nurse advice line instead of going to the ER.
It removes decision-making from a brain that is actively compromised by pain.
It gives the patient absolute, undeniable control.
It is the ultimate transition from being a passive victim of a biological short circuit to being the active architect of your own rehabilitation.
Okay, we have covered an immense, complex landscape today. Let's pull all of this together.
We have mapped out a complete paradigm shift. We started on the front lines, in the rapid-fire chaos of the emergency room, exposing how the triage trap fundamentally fails chronic, long-term neurobiology. We zoomed down to the microscopic level of the spinal cord to examine the broken fire alarm, detailing how calcium floods into NMDA receptors, structurally rewiring the central nervous system to generate agonizing pain in the absence of tissue damage.
We navigated the heavy toll of psychiatric comorbidity, observing how depression and pain form a bidirectional, self-sustaining biological loop.
We confronted the systemic failures and biases of trying to measure subjective suffering against objective scans. And finally, we laid out the tactical blueprint for a strategic pivot, abandoning the fruitless search for a passive cure, and instead building a multidisciplinary cabinet to climb the upward spiral of active biopsychosocial recovery.
It is a profound, gritty transition. We are no longer trying to mechanically fix a broken machine. We are rehabilitating a hypervigilant protective system that has simply learned to do its job too well.
If you or someone you love is sitting there right now dealing with chronic pain, I want to bypass the medical jargon and say this directly to you based on the absolute highest level of scientific evidence we have. The sheer, overwhelming complexity of what you are experiencing is not in your head.
You are not crazy.
It is a deeply intricate, scientifically validated neurobiological and psychological reality. It is a structural disease of the human nervous system. It requires immense patience. It requires radical self-compassion, and it requires a tactical strategy to untangle. You are not making it up, and you are not broken beyond repair. Your alarm system is just stuck on maximum volume.
And the most hopeful takeaway from all of this science is this. Neuroplasticity, the exact biological mechanism that trapped your nervous system in this cycle, is the exact same mechanism that can slowly, deliberately wire you back out of it.
That's amazing.
Which brings us to a final, much broader thought about how human biology operates. If our central nervous systems are plastic enough to learn how to produce agonizing physical reality, long after our bodies have fully healed, simply based on perceived threats, stress, and deeply held memories, what other realities is your brain currently building, reinforcing, and quietly making permanent without you even realizing it?
That is a staggering thought to leave on. The brain doesn't just perceive reality, it actively constructs it, for better or worse. We have to be the conscious architects of what it builds. Thank you for joining us on this deep dive. Keep questioning the systems around you, keep demanding better answers, and absolutely review these clinical sources for yourselves. Until next time.